It's a pleasure to be with you this afternoon to talk about a topic that's really dear to my heart, and I don't have anything to disclose. So a few years ago, Linda Villarosa, for the New York Times Magazine, wrote a piece about why America's Black mothers and babies are in a life or death crisis. And she said that the answer to this disparity in death rates had everything to do with with the lived experience of being a Black woman in America. And I'm sure this audience is well aware of the sort of longstanding racial and ethnic disparities in maternal mortality rates in this country. And here's data from the CDC on pregnancy-related mortality ratios. And again, we're talking about deaths that occur up to 1 year postpartum. And you can see here that Black women are over 3 times and Indigenous women are over twice as likely to die as compared to white pregnant women. These disparities are even more acute in our cities. And I currently work in Philadelphia. I've been here for about 11 months. And a recent report by the DOH here sort of outlined the maternal mortality crisis here in Philadelphia, showing that Black women are about 4 times more likely to die as compared to white women. I spent 20 years of my career actually in New York City at Mount Sinai, and there were long-standing disparities. And the most recent report from the New York City Department of Health and Mental Hygiene, summarizing deaths from 2011 through 2015, found that Black women were 8 times more likely to die as compared to white women. Interestingly, in New York City, you find that Latino women were about 3 times and Asian women were about 4 times. So while nationally you may not see those same trends, in specific cities, I think it's really important to understand our population and to understand the different pregnancy-related death rates. An important part of this story is the fact that this goes beyond socioeconomic status. Here's again data from the CDC showing us pregnancy-related mortality ratios by educational attainment. And you can see here that a Black woman with a college education on the right side of your screen in green is more than 5 times more likely to die as compared to a white woman with a college education. And in addition, when you compare that Black woman's pregnancy-related death, you can look on the left-hand side of your screen and notice that a Black woman with a college education is almost 1.5 times more likely to die as compared to a white woman with less than a high school education. These disparities are intertwined. Long-standing infant mortality disparities have occurred in this country, and here's data showing you infant mortality data. And you can see here from 2018 that Black infants are more than twice as likely to die in the first year of life. You also see that rates are elevated for Indigenous infants. Again, when we think about specific cities, the death rate in New York City is about 2.5 times more likely for Black infants. And I just wanted to make sure that we think about geography as we talk about these disparities. So what is a disparity? And I think Margaret Whitehood in the early 1990s to WHO audience talked about health equity and talked about it as sort of a social justice issue. So an inequity, a disparity is something that's unjust, and that there's this acknowledgement that we're talking about something that's not a simple difference. Here is a definition by Paula Braveman from UCSF that I have always found quite helpful. Health equity and health disparities are intertwined. Health equity means social justice in health. No one is denied the possibility to be healthy for belonging to a group that has historically been economically, socially disadvantaged. Health disparities are the metric we use to measure progress towards achieving health equity. But death is just the tip of the iceberg for both moms and very preterm infants. It's received a great deal of attention over the last 4 or 5 years in this country. The fact that for every maternal death, approximately 100 women experience a severe maternal morbidity. These are called life-threatening diagnoses or undergoing a life-saving procedure during their delivery hospitalization. Things like shock, amniotic fluid embolism, eclampsia, hysterectomy. We also know that very preterm infants face severe infectious, respiratory, neurological, and neurosensory morbidities. We know these are associated with neurodevelopmental disabilities, and we also know that it places these infants at a disadvantage over the life course. We also know that similar to what we know around death, that racial and ethnic disparities exist for both maternal morbidities as well as very preterm birth morbidity. So how did we get here? I think there's a growing recognition with with COVID and with George Floyd and all the things that have happened over the last year. The United States is finally sort of recognizing the role of structural racism in this country. And I think these four examples are sort of helpful for us to think about when we think about the impact of racism on health. Let's start with unequal access to resources and thinking about the Social Security Act in 1935, which included today's welfare benefits of unemployment and Social Security. It excluded individuals who worked on farms or as domestic help, which were primarily jobs held by Black Americans and people of color in the 1930s. So thus, from its very inception, it created a system where government aid was reserved primarily for white people. I think many of you are familiar with redlining. In the 1930s, the government began the practice of redlining neighborhoods based on how secure they were to invest in, and redline the neighborhoods with the highest risk. Not surprisingly, redline areas were occupied by Black families. Those neighborhoods rarely qualified for federal housing assistance, and they became underdeveloped, and it created a cycle that deterred future investment. So even though the practice was eventually banned, you can see the effects today. And in fact, you're reading more and more about it in our literature. There was a recent AJPH paper that came out with the senior author, the previous Commissioner of Health for New York City, Dr. Mary Bassett, that showed the association between historic redlining in New York City and the heightened risk of preterm birth in those neighborhoods. We know that there are numerous reasons why Black women may mistrust the healthcare system because so many policies and practices were used to devalue them. If we think about James Marion Sims, who used to be called the father of gynecology, who performed multiple experimental surgeries without anesthesia on enslaved Black women. You've enforced eugenics programs that sterilized Black women. And healthcare segregation that continued into the mid-1960s with Black families barred from certain hospitals even after the Civil Rights Act. Hospitals serving primarily folks of color were under-resourced, and we actually continue to see this pattern today. And I'll share some of the research that we have done that's sort of shown some of this. And then finally, which I mentioned in the beginning of this section, was just the tumultuous events, including the COVID crisis and its disproportionate impact on people of color, the George Floyd events, and how this country, all that it's been through over this last year. And we also need to remember the storming of the U.S. Capitol and the impact that that's had on how people view racism in this country. Well, what about the contribution of quality of care to racial and ethnic disparities in health and healthcare? So I think many of you may be familiar with this report that was published in 2002 from the Institute of Medicine entitled Unequal Treatment. It documented that there were racial and ethnic disparities in care across a range of illnesses and services, that people of color often received lower quality of care. And they also acknowledged in that report that provider stereotyping and bias contribute to these disparities. Well, what about in the context of maternal and infant health? I've started this conversation with you this afternoon talking about the racial and ethnic disparities in both maternal and infant morbidity and mortality, and they've long-standing for decades, if not centuries. We know there's growing evidence now that quality of care is an underlying cause of some of these disparities. We also know that quality of care varies quite dramatically across delivery hospitals, and we've seen a number of papers on this topic ranging from cesarean sections to a number of obstetric metrics, as well as neonatal and intensive care units. And the Vermont-Oxford Network has done a lot of work showing us the wide variation in quality across NICUs in the United States. And site of care is receiving increasing attention as a mechanism for disparities. So I'm a health services researcher, and we often think about thinking about it at the patient level, community and neighborhood, provider, and system factors. So here's sort of a model to sort of help us think about how we might think about the linkages between hospital quality and organization with maternal and infant health disparities. On the left-hand side, you see sort of the profound influence of structural racism and discrimination, sort of driving many of these things, many of the social determinants. We think about patient-level factors, age, education, poverty, language. We think about knowledge, beliefs, health behaviors, psychosocial factors such as stress, the weathering hypothesis, the idea that um, uh, the stress from discrimination and racism has an actual impact on women's bodies. And it actually, that Black women advance more quickly during the idea is that Black women advance more quickly in age, and so they have reproductive outcomes that parallel white women at a much older age. Thinking about social support, community and neighborhood factors such as social network, the built environment, housing, provider factors, knowledge, experience, implicit bias, communication skills, and then system factors, access to high quality of care. These combine for the health status of a woman. She may or may not, when she gets pregnant, have hypertension or diabetes or other factors that put her at an elevated risk for potential maternal morbidity. And they also are on the pathway, certainly hypertension and obesity, for very preterm birth. They interact with the hospital, and we can think about sort of the structural characteristics and the hospital factors. And we can also think about quality of delivery and neonatal care, and then ending in the outcomes, the severe maternal morbidity, very preterm morbidity and mortality. What's not on this conceptual model, but when I'm just talking about moms, I often really emphasize, and I want us to remember to think about, is that this is really a care continuum, a care continuum issue. And although the research I'm going to talk about is really focused around delivery, hospital, and NICUs, we really need to think that and recognize that it's preconception, antenatal care, delivery hospital care, and postpartum care that are all time points in which we can intervene to impact these outcomes. So I thought I'd share some of the work that we've done that's been funded by NIH. We had essentially two parallel R01s looking and examining the contribution of quality of care to racial and ethnic disparities. In one grant, it was for severe maternal morbidity, and in the other grant, it was on very preterm birth morbidity and mortality. The first phase was quantitative analyses to examine hospital risk-adjusted severe maternal morbidity rates in one study and very preterm birth morbidity and mortality rates in the other study, and then look at the racial and ethnic distribution of deliveries. The next phase was qualitative interviews in hospitals, both revolved around labor and delivery, and then revolved around NICU care, examining safety culture, quality improvement, and other factors that may explain the wide variation in hospital performance. Next, we did focus groups with mothers who had experienced a severe maternal morbidity, and then mothers who had had a very preterm birth infant who had an extended NICU stay to better understand their decision-making about where they went for hospital care, as well as barriers to receipt of high-quality care. And then the final final phase was a dissemination effort to increase uptake of best practices. So we used New York City vital statistics data linked with discharge abstract data for all New York City deliveries for the years outlined on the slide. We used mixed effects logistic regression to calculate risk standardized severe maternal morbidity rates and very preterm birth morbidity and mortality rates for each hospital. We ranked hospitals based on these metrics, and then we assessed Black-white differences and Latinx-white differences in delivery location. So you can see what the outcomes were that we actually used. And we used the CDC algorithm for severe maternal morbidity. And just to remind you, it's based on, for the years, it's now up for ICD-10 codes, but for the data that we used, those were ICD-9 diagnoses and procedure codes. Again, for life-threatening diagnosis or a life-saving procedure. And you can see examples here on the left-hand side. For the infant outcome, we looked at very preterm neonatal death or up to 1 year in hospital, or severe neonatal morbidity, again, using ICD-9 codes for NEC, IVH, BPD, and ROP. And I should just point out to you the reason, this audience probably knows well, but when we think the reason this very preterm morbidity and mortality outcome is such a good one when we're thinking about infant mortality disparities, is that, remember, very preterm births are about 3 times more likely to occur among Black women than white women. And those very preterm births, account for more than half of infant deaths and about 2/3, 60% to 2/3 of neonatal deaths. So they're really the large driver of the disparities, racial and ethnic disparities. Both models were risk adjusted for patient case mix, including sociodemographic characteristics, clinical and obstetric factors, maternal comorbidities, and then infant characteristics when we were thinking about the very preterm birth morbidity and mortality model. So here are the observed rates of severe maternal morbidity in New York City. And you can see that Black women were nearly 3 times and white and Latino women were nearly twice as likely as white women to experience a severe maternal morbidity rate. And national numbers are more around 1.4% across the country. So our rates are elevated in New York City compared to national estimates. Here you can see the hospitals ranked from lowest morbidity to highest morbidity. And these were 40 New York City hospitals with deliveries. You can see the risk standardized rates. And I think the take home message here is this wide variation remember, these are risk adjusted rates here. So you can see there's a 6 to 7-fold variation in risk-adjusted rates across New York City hospitals, suggesting that a woman's risk of having one of these severe experiences during her delivery hospitalization could be 6 or 7 times higher in one hospital than another. We next divided the hospitals based on their ranking in tertiles, the low morbidity, medium, and high morbidity clusters. And we examined the distribution of deliveries by race and ethnicity among these hospital clusters. So you can see that in the light blue, those are the low morbidity. So of all the Black deliveries that occurred during this period, 23% occurred in low morbidity hospitals, as opposed to all of the white deliveries that occurred during this period, 65% occurred in low morbidity hospitals and 33% of Latinx deliveries delivered in those same hospitals. That's opposed to the high morbidity cluster of hospitals, where you can see that of all the Black deliveries, 37% delivered in those hospitals, 18% delivered of whites delivered in those hospitals, and 29% of Latinx. And we did some simulations with one of the methodologists on our team to sort of try to understand what that impact was. And we've done it in a number of different ways, but our earlier work was really sort of a simpler model where we just sort of said, what if we kept everything the same about a Black woman, her age, her BMI, whether or not she has hypertension, et cetera? The only thing we changed was her hospital of delivery, so that Blacks went to hospitals in the same proportion of whites. So that 10% of Black patients went to 10% of white patients went to hospital A, the lowest morbidity hospital, then 10% of Black patients went there. And if the next 5% of white patients went to hospital B, then the next 5% of Black patients went to hospital B. We did that across the whole distribution. And then we bootstrapped and did it like 1,000 times and found that up to about 48% of the Black-white disparity and about 1/3 of the Latinx white disparity in New York City hospitals could be attributed, up to that amount could be attributed to the hospital delivery, suggesting that between hospital differences was part of the story for these racial and ethnic disparities in New York City. So we did, again, in a parallel study, we did similar work looking at observed very preterm morbidity mortality rates for very preterm infants in New York City. And you can see the observed rates here. Again, Black and Latino infants, very preterm infants had higher rates as compared to white infants. Here you can see that there was quite a bit of variation across the hospitals in terms of risk adjustment when we did this for the very preterm birth morbidity and mortality, and there were only 39 hospitals, not 40, because one of them had next to no very preterm infant deliveries during this period. And when we did a similar thing and divided the hospitals into low, medium, high morbidity, here's what we found when we looked at the distribution of deliveries by race and ethnicity. So you can see that in the blue, which is remember the low morbidity cluster of hospitals, you see that there's not that much of difference between Black and white, and Latinx are a little bit more, but not much. Where you saw a much bigger, more pronounced difference was really in the high morbidity cluster of hospitals, where 43% of Black infants were delivering in those hospitals with the highest rates, or those NICUs with the highest rates of very preterm birth morbidity and mortality. So the next phase of the study was really two things. Remember, I showed you both in the context of the mother's outcomes, risk-adjusted outcomes, and when we risk-adjusted the hospitals, we saw a wide variation. But I also showed you that we found a similar thing when we did it for very preterm birth morbidity and mortality. There was wide variation. The part of the story that I have not shown in these slides, what did not show in these slides, is we actually looked at the traditional hospital characteristics that one might think about that might explain some of that variation. Level of NICU, volume of deliveries, or in the context of the infant, very preterm birth, the volume of very low birth weight infants in a hospital, ownership, teaching status, those traditional factors. And while they were associated with the outcome, they did not explain that wide variation. So it really led us to do qualitative interviews with hospital leaders and leaders both on labor and delivery and NICU, and then frontline staff, to better understand. And here's sort of the framework we thought about. We could be asking them questions about structural characteristics and learning more about that, thinking about organizational factors, culture, leadership, communication, use of evidence-based practices in terms of clinical processes, really thinking about approaches to patient safety, and then the patient outcomes, and asking them their impression of these outcomes. We layered this with questions around disparities and bias, diversity of the workforce, communication, and then families. So we used this positive deviance framework, which is really the idea that are there hospitals within the system that are doing quite well, having low morbidity rates for moms or low morbidity rates for very preterm infants? And are there things we could learn from those hospitals? And what's particularly interesting that we're still sort of working on at fully analyzing is finding hospitals that have, like, for example, the similar case mix in terms of payer status. So let's say a hospital that had a high Medicaid status, a higher percentage of Medicaid. Could you find a hospital that was that had a high morbidity, that had that attribute, and then a hospital that had a high Medicaid hospital that had low morbidity? And then going into both of those hospitals to understand what they do differently, right? So we selected 4 hospitals from the high morbidity group and 4 from the low morbidity group. So we had 8 New York City hospitals for each study. We did 50 interviews for the severe maternal morbidity study, and we did 44 interviews for the very preterm birth study. We did this work in 2017 and 18, semi-structured interview. All the respondents were consented, interviews were audio taped and transcribed, and worked with qualitative research, a colleague who was a qualitative research expert and had a lot more background in that area, and so worked with her. She was blinded to the hospital ranking, but came into the hospitals. I went with her, as well as a couple staff, and we did these interviews together, and she primarily did the interviews, and she did not know where the hospitals ranked. So just here are some of the themes that were true for both high and low performing hospitals. Everyone believes staff communication is a critical factor in quality and safety, but hospitals vary in what they have done or do to improve communication. There were, in New York City hospitals, nurse staffing issues were a big issue. And this is, by the way, these are the themes that were common for both moms and babies. So there were a lot of shortages and a lot of variation in the experience of nursing staff, and it was a concern for many hospitals, whether they were low or high performing. There was wide variation in quality measurement and tactics used for improvement, not only in terms of the metrics that were used, but the staff who were assigned specifically for quality and safety. And we noted that individual adverse events were more likely to lead to quality improvement than monitoring trends. At the time we did this work, no one was analyzing their data to compare performance across race, ethnicity, or insurance source. So here are some of the themes that we found to be more common among the high-performing hospitals. There was a stronger focus on standards and standardized care. There was a stronger focus on physician-nurse communication and teamwork. There was more sharing of performance data with nurses and other frontline clinicians. Senior leadership was more involved in day-to-day quality activities, and there was more awareness that disparities, racism may be present in a hospital and could lead to differential treatments. So the next phase was with actual mothers who had experienced severe maternal morbidity, or mothers in a separate 3 focus groups. We did them among mothers who had delivered infants at less than 32 weeks gestation and had had an extended NICU stay. Again, what I think was unique about this, I want to just mention, we didn't just do focus groups with women who had had a delivery. We did focus groups with women who had actually experienced a severe maternal morbidity during their hospital stay. So those were 3 focus groups stratified by race and ethnicity. So we had 3 groups, one that was white and other self-identified, Black, self-identified, and Latina self-identified. We did a similar structure for the 3 focus groups of mothers of very preterm birth infants. And then we explored how women experience care. So on the left, you can see sort of some of the themes for the focus groups for the mothers who had experienced a severe maternal morbidity event. And I think the take-home message from all 3 focus groups was how traumatizing and scary these events were, to the point that, even a year and a half later, one woman was talking about how she could never wanted to have a child again. And that was a theme that many of the women related to. But it was complemented with gratitude, because a lot of these women thought they were going to die during their delivery hospitalization, and so they were very grateful to the clinicians that cared for them. Another theme was poor communication. These are rapid situations and severe severe conditions, and I think a lot of women talked about how they had just no idea what was going on and that no one explained anything that was going on to them. And you see a quote here about, "They just rushed me to the OR. That was it. I was just lying there. I'm cold. I'm shaking. I know I'm not feeling good, but nobody's telling me anything." I think this theme of not feeling heard was something we heard a lot about. And again, this echoed what we heard in the press from Serena Williams and others at the same time we were doing this work, about how people just felt like a lot of times they were not being listened to. And one woman actually had to diagnose, she was a nurse practitioner, diagnosed her own pulmonary embolism. And the Black and Latino mothers talked a little more about subtle discrimination, feeling that their access was limited by their insurance status, because the majority of the women in our focus groups who were Black and Latino had Medicaid or Medicaid managed care insurance. There was less time spent on education, and there was a lack of continuity of care. You can see that it was a little bit different, the themes that came out from the mothers of the very preterm birth infants. Um, the biggest thing for the NICU mothers was really the distress from the birth experience. Many of these same women, by the way, who had severe maternal morbidity, many of the women in our very preterm birth focus groups, we found out through the conversations had actually experienced, preeclampsia or had a hemorrhage. So a lot of them were actually had severe maternal morbidity as part of their delivery experience. Um, there was a lot of discussion about struggles of parenting in the NICU, and there was an interesting perspective on quality of care and a real focus on the importance of communication and preparation. There's a lot of positive feelings around the NICU. Folks from the folks we talked to about how the staff fostered trust and mitigated feelings of blame. But differential care also came up. Suboptimal communication. Some clinicians spoke to women of color in dismissive or accusatory manners. And there was a discouragement of patients' use of language other than English. So that sort of it sort of showed you some of the work that we've done on the first 3 phases of that work. But I wanted to just sort of also take a minute about and talk to you a little bit about some of the work, because alongside what made this whole experience so unique is this data set. We were allowed, in having both of these studies running in parallel, to sort of explore more of the mom-infant dyad as well with these data sources. And one of my colleagues really took the lead in looking at, she was talking, she works in Europe, and she talked a lot about how everything is done in such silos, and all the long longitudinal cohort studies on very preterm infants often don't have much at all about following the mothers and what's happened to them. And so we looked in this data set to try to better understand what the impact of severe maternal morbidity was on very preterm infant outcomes. And we found that in this group that 12% of all the very preterm infants had a mother with severe maternal morbidity. We found that the 1-year mortality of these infants was higher among those who had a mother with severe maternal morbidity, 11.2% versus 7.7% among those who did not have a mother with severe maternal morbidity. And even after, accounting for maternal characteristics, obstetric factors, et cetera, in our adjusted rates, we found a risk of 1.39, an elevated risk. The other thing that we did that was quite interesting is we wondered about how hospital performance for moms and hospital performance for these very preterm infants, was it correlated? And you can see here we found a correlation of about 0.32, which is not in the quality literature. It's about, low to moderate. But we thought it might be higher. But what we found particularly interesting was what was it like for, let me just stop for a second. We found that correlation, but what we were really most interested in is trying to understand the cluster of patients who actually went to hospitals that were ranked, meaning had high risk adjusted rates for moms and babies, and what did that look like? So we did cluster analysis to identify groups of hospitals that were similar based on both metrics, and you can see them here. And what was striking is that in the cluster of hospitals that was poor for both moms and babies, we found that Black women were 7 times and Latinx mothers were 5 times as likely to deliver in those hospitals as compared to white women. Another colleague of mine who has been doing a lot thinking about neighborhood factors has looked at neighborhood racial and economic polarization, hospital delivery, and severe maternal morbidity. And what she really wanted to look at was whether, we're calling it racial and economic polarization, but it's essentially, segregation here. Was that associated with severe maternal morbidity? And if it was, does hospital, explain part of this association? So we use the index of concentration of the extremes, which is a measure of racial and economic spatial polarization that's increasingly used to monitor population health inequities. And we found that women who lived in zip codes with the highest concentration of poor Blacks relative to wealthy whites experienced about 4 cases of severe maternal morbidity per 100 deliveries compared to 1.7 cases per 100 deliveries among women in the neighborhoods with the lowest concentration. And we found that a significant, about a third of this difference was attributable to delivery hospital. And that's an article that was published in Health Affairs. It's on the left. On the right, I just wanted to show you a blog that Dr. Jonovic wrote, where she was really starting to wrestle with this, and why I found this map so particularly interesting. As you can see that in red here are the neighborhoods with the highest relative concentration of poor Black households. And what was really interesting, we think about it in the context of severe maternal morbidity, and we know those neighborhoods have twice the risk. But what was so striking is that during COVID, when you'd see the maps from the DOH about the neighborhoods that were most hit by COVID infections, it looked quite similar to this map. So I've shown you some of the research that we've done about between hospital differences being a big component of the racial and ethnic disparities. Some of the work we've thought about when we think about the mom-baby dyad, and I think it's an important perspective to think about when we think about disparities. We've talked a little bit about thinking about neighborhood and other factors that contribute to these disparities. And the one piece of work that I did not have time to share with you is just some work that we did looking at within a given hospital. So I talked about between hospital differences driving some of the disparity. Well, we did some work looking within any given hospital. Do Black mothers have an elevated risk after you adjust for, sociodemographic clinical factors? And we found that even after adjusting for insurance status and other factors, Black women have an elevated risk as compared to white women, which raises some other questions about, what is it? Is it around the use of evidence-based practices, around quality of care? What's driving those disparities within the hospital between race and ethnicity? And again, it's only as good as our data is. We can't capture everything in our data, so there are other factors that are outside that we have to acknowledge. But I think all of these things sort of build this case. So how might we proceed? Where do we go from here? And I mentioned really thinking about a life course perspective when we think about levers to reduce racial and ethnic disparities and severe maternal morbidity and mortality. And we can think about culturally appropriate contraception and really shared decision making in those choices, optimizing preconception health, thinking about all the new models of care that are possible, centering, which is group prenatal, has, has mixed data around it, but there's a lot of positive things around the support that's offered from that model. Medical homes, there's a lot of work being done. The area that we work on a lot and that I think about is in terms of delivery and hospital care, standardization, bundles, disparities dashboards where you look at your quality metrics and you stratify by race and ethnicity, and then new models for postpartum care, such as patient navigators and case management. Now, most of this is really focused on the mom. I'm an OB/GYN, and so that's where when I think about these levers, but I think some of these would potentially obviously have an impact on very preterm birth morbidity and mortality, as well as, infants. But I think the other part of the story that we've learned, we really need to layer in when we think about quality improvement, our efforts to eliminate both implicit and explicit bias, efforts to enhance our communication, not only between our team members, but also clearly with our patients, and engaging community. So I was part of there's a program, I think many of you may be familiar with it, called the Alliance for Innovation on Maternal Health, which was started by ACOG. It was a contract with HRSA. It's now expanded to a number of professional societies, family medicine, anesthesia, nurse midwives, number of departments of health, community organizations, all coming together to try to improve care and standardize it across delivery hospitals across the United States. Started with some of the most preventable causes of death, hypertension, hemorrhage, venous thromboembolic disease, but then moved on to do things in the postpartum area around mental health as well, other areas. I was part of the bundle on, was able to co-lead the bundle on reducing peripartum racial and ethnic disparities in hospitals and giving hospitals and health systems some starting points to think about. And here are the highlights of what we recommended. The importance of collecting self-identified race, ethnicity, and language data in electronic medical record, disparities dashboard, which I've already mentioned to you, and then utilizing quality improvement tools to address the gaps that are identified, to provide education on cultural humility and shared decision-making, implicit bias trainings, including community members in quality committees, which is something that I think we have a long ways. I think there are very few people have some patient advisory committees, but that's very different than having them sort of really thinking about quality and engaged in that kind of work. And one of the big parts was really promoting a culture of equity that's similar to a culture of safety that we've all in hospital care spent a lot of time working on over the last 2 decades, and sort of thinking about equity in that same framework. And just like we have a mechanism for reporting safety issues and anonymous reporting, that we needed those kinds of mechanisms for reporting racism and disrespect. I just wanted to quickly share that the CDC has been doing some work on trying to help maternal mortality review boards across the country be able to identify how racism may have played a role in a maternal death. And remember, these are the committees that review each death, each pregnancy-related death, and then the idea is that they report that information up through this McCrea, through a database that the CDC links them with, so then the CDC can aggregate all that data and report out. And they asked us to sort of help them design a consistent approach for documenting racism and discrimination as contributing factors to pregnancy-related deaths. So that's now part of this a standardized form that all the maternal mortality review boards that are participating can use. And I believe that's about 42 states right now. And you can see we added discrimination, interpersonal racism, and structural racism to that. At Penn, we've been really active in sort of thinking about how we might take some steps to actually improve maternal health equity. And we've been taking a number of things. We have a team leadership goal so that the 5 delivery hospitals are working together, having a goal to reduce morbidity and mortality among Black women. And we've made significant improvements and really decreased our rate already in the first 10 months of this program. We have implicit bias trainings. We have speakers on health equity. We have a disparities dashboard in the Department of OB/GYN here where we look at our quality metrics stratified by race. We think about ways that we can leverage technology to improve quality and reduce disparities, and we have a number of programs going on. And then we have a couple of other things around education and awareness. And then the last thing I'll just briefly chat about is the 4th phase of those grants that I talked about, which was the dissemination phase. And we had a big maternal child health equity summit co-sponsored by the New York Academy of Medicine this past January, where we brought together, invited all 40 hospitals from New York City. We invited, the person who runs the Vermont Oxford Network, Jeffrey Horbar. We invited some investigators from California. They do some really novel, they're collaboratives, both on the NICU side and on the maternal side, have done some really interesting work on quality and equity. We invited Karen Scott, who's been doing a lot of work on obstetric racism, and we invited community organizations. We got together, we presented our research, we had others present their research and best practices, and we had a conversation about mothers, about babies, and about the mom-baby dyad in terms of disparities. And here are some of the themes and the action steps that were recommended from the groups. And it was obviously online, it was a virtual event, but we had over 1,000 people register, and we had about 460 people who participated. And really the themes were about acknowledging the role of structural racism, the importance of having a life course perspective, thinking about the mom-infant dyad, if we're thinking about ways to interrupt disparities in the intergenerational transmission, we really need to be thinking about that. One colleague from the Mass General who does a lot of work on quality improvement in the context of obstetrics talked about no quality without equity. So every component of her quality improvement work has equity as part of it. And then the action steps were really sort of a repeat of a lot of the things I've said about standardizing care, promoting a culture of equity. But one of the things people talked a lot about was really focusing and integrating the lived experiences of Black and Brown women for all this work, engaging communities, supporting doulas, addressing the midwifery shortage, and that really advocacy has an important role here. So I'll end with this quote by Lisa Cooper, who's a professor at Hopkins, who said, "Most health disparities are avoidable. They result from decisions we make as a society regarding how we allocate our resources and how much injustice we are willing to accept as a fact of life." Thank you.
Thank you so much, Dr. Howell. This was an amazing talk. We have a few questions. I'll begin the question and answer session. To our listeners, to ask a question or send a comment, click on the Q&A on your screen. Select Ask All Panelists and type in your question and then hit send. So there's a number of questions in line. The first one is, were stillbirths included in the identification of VPT births?
Such a great point, and there's so much work that needs to be done. And no, they were not. We only got live births. We've tried many times when I was in New York to get the stillbirths because we really wanted to do those analyses, and we just had a lot of trouble getting our hands on that data. It's never been quite clear to me why it's so difficult, but we have never gotten it.
Sorry, things are jumping on my screen. Someone wrote in and said, "I had a disturbing experience in NICU. A nurse was hostile and made insulting statements about her son being mixed race. It felt that there was no avenue for maternal feedback on such treatment. Is there a role for increasing maternal voices and power?" I'm going to just a personal note to this, it seems like this is a huge part of the problem to some degree. And I'm not sure what you might have to say to that.
I think the person brings up a really important point, and I think there's this growing recognition that this is a big part of the problem, right? That we're not listening to people and we're not hearing, and that, it's interesting because when we went around to these NICUs and did these interviews, there was acknowledgement. They don't feel like they treat babies differently at all, right? But they acknowledge that they do treat families differently, and whether that's based on biases, whether it's about I can go through all the different reasons about it, but I think when you really talk to people, they start to acknowledge that they may be treating people differently, and that might be actually influencing their care. I don't think people are actually. No one will acknowledge that when you first ask them that, but when you delve in and you start to have a real conversation with people, you can even hear the providers saying some of those remarks. So there's no question that I don't think we do a good enough job listening to our patients. And I think I think as a field in OBGYN, and I think many labor and delivery units across the country are trying to encourage and help with doula programs, just to make sure there's one more person in the room who can kind of make sure that help advocate for that person, who's the birthing person in the room. And so I think that's an important part of it. I think there is a growing recognition that this is an issue, and I do actually, not all physicians, so don't get me wrong, I can't speak for everyone, but I do think there's a growing recognition around this, and I think people are starting to take a moment, and implicit bias training, for example, is being, has been implemented not only for our providers, but our staff at the hospital that I am at. And I don't think a one-time training can solve all this, but I do think it can help people's awareness. And that's the first part of this, right? And then having mechanisms, supporting mechanisms, and then mechanisms so that patients can actually speak up and report if something didn't work well. And I think that hospitals have those, and patient experience really matters. And so I think we've made a lot of progress, but we have a long ways to go.
So I'm going to use my privilege as a moderator to ask one of my own questions. So the work that you presented is obviously done in cities, but I think it's something like half the counties in the country don't even have OB services, much less a hospital with OB services. How does all this, I don't know if translates the right word, but how do we bring some of this awareness and change to more rural and underserved geographic areas?
Great question. And the work we've done has really not ever been absolutely correct. We've really focused on New York City, which is a big urban center, and a very different, just our volumes in our hospitals are so much higher than, over 50% of the hospitals have, you're absolutely right. I think that there are some shared lessons around first of all, I think we know that the racial and ethnic disparities occur even in rural settings, right? So we still know from some of the data, and even some national data that people have looked at, that risk of severe maternal morbidity, for example, for an Indigenous woman who is from a rural location is higher than a white woman who's from a lower, right? And we can follow that through. So we know that disparities in rural areas are a major issue as well. When we think about some of the lessons we learned from hospitals that are doing well and have low morbidity, there's no question that resources matter. But I think what we've learned, some of the things I showed you are some things that I think may not cost that much money. It's more learning that it's important. So for example, I guess you have to have the data infrastructure, the data folks to be able to share the data, but sharing data, like if you're looking at the data, then start to share it, because that seems to matter. Like when people on the front lines understand what's going on, how well they're doing, and there's more buy-in to it, that seems to matter. And so that can be done in any hospital setting. So some of the lessons we learned from the hospital comparisons of low morbidity versus high morbidity hospitals, I think don't require a ton of resources. It requires sharing of best practices. And so what the good news is that the CDC is now, paying and sponsoring a lot of these perinatal collaboratives in different states to work with hospitals and health systems to work together and learn. So I think being part of a collaborative and sort of sharing and learning some of these lessons, I think would be an important thing. And then I think the last part of, I'm just going to answer real quickly, is certainly from what I've learned with the focus groups we've done, and then also just, recently reviewed a lot of literature, and there's been so much growth in this area of patient perspectives, focus groups, et cetera, around these issues over the last 2 years, I'd say. And a lot of the themes are the same, right? It's about, having a voice. It's about support. It's about those kinds of things. And that can be done anywhere. That can be done in any hospital. So I don't have a solution for everything, but I think some of the lessons can be applied in rural settings.
Thank you. So I think maybe one more question, but there are many comments here saying that this was a wonderful, fantastic presentation. So I at least wanted to pass that along. You briefly touched on the inclusion of doulas. So there are a couple questions about having doulas by the bedside, research regarding doulas, and what progress is being made regarding reimbursement of them.
So, I think most of the data to date is about lowering interventions in the delivery, in the experience. So increasing birthing satisfaction, less likely to have an intervention like a cesarean. And so, and that's the data that we have about doulas. We don't have data that says if you have a doula, you're less likely to have a hemorrhage. We don't have data that says if you have a doula, you're less likely to have eclampsia, right? But we know. But so I just want to say what the data tells us is you're less likely to have an intervention, which we know for the long term for a woman's health and reproductive health is a good thing, because the more cesareans, right, you get a placenta that adheres and you can have one of these complications. So I just want to be clear on the data, because I think some people confuse that just having a doula there does not mean you're not going to have a severe maternal morbidity. But the idea that your voice will be heard, which we know is an issue for many women, and we do think contributes to some of these factors, and that you have another person to advocate, and we all need support, and that things to improve your birthing experience makes a lot of sense, that we would want to sort of propose doulas. And I think more and more people are starting to explore, we probably don't need them just during delivery. We know postpartum is difficult, right? We know half the deaths are occurring postpartum. So might we need to be integrating them there as well? And then obviously, an antepartum source of support. And some people are exploring models like coaching, one-on-one coaching to help people navigate the health system. So there's a whole bunch of different models that are being explored in that setting. So overall, I think that there's a really important role. I think we have to do work on the reimbursement. I don't know the latest. I believe there are 3 states that there's 3 states that are Medicaid is doing some reimbursement for doulas, but I know that not all of them have been so smooth. It's not like the Medicaid pool increased. It's moving that money from one thing to another, which is always problematic, because I told you, for example, the nursing shortages that all the hospitals seem to sort of talk about and all these other things. So it's very complicated. I think there's pretty much agreement that sort of supporting doulas is an important part of this story, but we do need more research about the ways in which they can be most effective. Can we really tie it specifically to, severe maternal morbidity or other severe outcomes? And I think that body of work is growing. But we definitely know increased birth satisfaction and lower use of interventions, which we know is better for women's health.
I was going to say, just the increased sense of agency and power, I think may not, like you said, prevent hemorrhage, but it could at least improve quality of life and lack of trauma. I think we're probably at the end. I suspect Bill or Christine is wrapping up now. And I just want to say again, thank you so much for a wonderful presentation this afternoon. This was absolutely fabulous. Thank you.
My pleasure. Thank you. Bye-bye.
Yep. Thanks so much, Dr. Howell. We appreciate it. And nice to hear that there's some malleable hospital-based implementation efforts that we could do to address this problem. So it's really great to hear. Just for everyone, before we sign off, just a reminder again that the video of this will be available in a couple of weeks on the website, and to check the website, our OBSSR website as well, for future webinars that are coming up. So again, Dr. Howell, thank you so much for your presentation. Much appreciated.
Sure.
Thank you.
Bye-bye.
Bye-bye.